Good afternoon, everybody, and welcome to Breaking Barriers Fall webinar series. This is our second webinar in this year's build up to our annual Breaking Barriers Symposium. Next slide, Daniel, and we're looking forward to a really interesting and important topic in terms of data interoperability. And as always, we always want to make sure we say thank you to our sponsors. So MHSOAC, the California Children's Trust, UCSF Dyslexia Center, which is going to do an interesting presentation in the symposium, Integrated Human Services Group, and my agency, San Diego State University Social Policy Institute. Next slide. My name is Steve Hornberger. I'm the director of the Social Policy Institute, and my co-partner and partner in crime, Richard Connect, has been working with me, and I'm sure almost every one of you knows Richard. This has been our third year together working on these webinars and the Breaking Barriers Symposium, and as many of you know, it's an absolute joy to work with Richard. Richard, anything you want to say?
Nope, back at you. Love the partnership and welcome everybody to our conversation with Daniel today.
Yes. And next slide, Daniel. So today's purposes, and I think the first one captures everything. Outline the urgent need to advance interoperability so that we can have comprehensive and collaborative services and supports for the youth and families that we serve. Clearly, they need more than just siloed information and siloed options. Daniel's also going to talk about his work with the National Action Agenda to advance upstream social determinants of health and health equity. Clearly, that's an issue that we're all dire in need of. And obviously, overview the cross-system data sharing concepts. And finally, he'll highlight some of his Stewards of Change Initiative Institute on their new training methodology. Next one. Daniel, if you could move on.
Yep.
I want to make sure you have as much time as possible because you have the important stuff. So obviously, this is building on a lot of the work that's already got underway in California in terms of the AB 2083. I believe that all of you are probably familiar with this at this point, and in fact, almost all counties are actively working to develop and design their MOU. I think given the requirement for the MOU and developing and expanding effective information and data sharing and outcomes management framework was the reason why we asked Daniel to present today. He is one of the national leaders in this, and he's going to highlight some of the work that he's doing nationally, but also focus specifically on some of the efforts and initiatives that are happening in California specifically. Next slide. So the children's system and youth system of care, I think you all have been involved with that for many years. And I think what's fascinating is they're working on their integrated care practice models, and 4 groups have already created their enhancements. That's the foster youth, family resource centers and prevention systems, education and school, and short-term residential treatment facilities and FFA providers. There are 3 groups that are now still working or just beginning on their enhancements. That's the regional centers, the parents and the biofamilies, and the tribes. However, all 7 groups will be taking the 4 chapters of the 2018 ICBM and through ongoing and monthly encounters and dialogue and design have suggested content modification, which will be incorporated into the 2020 3.0 version. It's exciting to see how we're continuing to evolve our core systems work and how people are becoming ever more comfortable and familiar and excited, frankly, about system of care work. Because I think we've all realized that no one system has the mandate, the resources, and the reach to address both the person-specific issues that we're used to and the social structure issues that exasperate such things. Next slide. And Daniel, I want to welcome you and let people know that we're going to hopefully have some time at the end for questions. Please put any questions as Daniel goes along in the Q&A box, and we'll pick those up at the end. And obviously, this will all be available once we finish. So Daniel, take it away.
Thank you very much, Steve and Richard. It's a great pleasure to be able to address you, even though it's virtual. Last year it was in person, and that was a whole lot of fun. So we're all getting acquainted and acclimated to this new digital virtual world. Hopefully it ends soon. We get to be in the room together next year, if not sooner than that. So like all of you, we've been adapting our work to this virtual platform. And today, I think the topic, which is up here, this is the first topic I want to describe, is really the National Action Agenda to Advance Upstream Social Determinants and Health Equity. And this is a project that we're doing with Stanford Center for Population Health Sciences. And I'll speak more about that as we go along here. The origins of this are that we're planning our 14th national event last January, and we do in-person symposia we've been doing for a while, and we were sort of merrily moving along, and we're closely talking with Stanford about bringing this interoperability work back to California. We've been doing it the last bunch of years on the East Coast. And then all of a sudden, this pandemic arrives, and we kind of threw our plans out the window and started from scratch again to say, well, what could we do as a small organization that has a national reach to try to really both recognize the challenges ahead of us and operate in a way that could actually make some meaningful change to the structure and the function of our safety net systems across the country. So a really ambitious and bold initiative that we are right now in the beginning stages of, and I'll explain a little bit more to you about that. And I think it's relevant, and the reason I want to share it with you is because we're no longer nibbling around the edges, right? The world is a different world. Whatever the new normal is, hopefully is not the old normal, and we'll be able to change some things that were and still are hugely impactful on families and children and communities across the country. So as we know, the pandemic is really showing us what exponential means. For those of us who didn't take calculus in high school or college, it's a concept of exponential change. And now every night on the TV or however you receive your news, you see those charts and those graphs that go straight up, and that's an exponential curve. You were usually thinking about linear, like 1 + 1 = 2, + 1 = 3, + 4. We're in a different world, and that exponential change raises all sorts of questions about how do we respond to that change, because in many ways it's not only exponential, but it's also existential in terms of our ability to adapt to it. And that really requires thinking about scale and rate and scope of the changes that we need to make to take equal and commensurate action to maybe get ahead of this or to address the challenges that are coming, right? I'm sure all of you who are service providers or involved in the care and systems of care are feeling the pressure of the tsunami of need. And there is no doubt that that will continue to increase, especially as the numbers go up, which we're seeing day to day. So how do we think differently? How do we think not incrementally is a huge, big question. So we approach this work with some core, an ethos that says, first do no, and I added the word more harm. We ought to be seeking justice and guaranteeing equity and keeping promises, and most of all, practicing kindness. The world we live in, the challenges of doing everything remotely is unbelievably challenging. And we want to make sure whatever we do is not more harmful than previous actions. I'm sure many of you have seen this expression before. If you want to go fast, go alone. But if you want to go far, go together. And I think that we want to do both. We want to go fast. So there's a need for individual action. There's a need for ambitious activity. And we also need each other to go far together in order to reach the goal of, as Richard already put out there, systems of care and the change that involves multiple systems, which is a really fundamentally different way of thinking about the world than when we're used to. Back in 1962, Thomas Kuhn, the author of The Structure of Scientific Revolutions, which I'm sure everybody read and discussed in undergraduate years, is really full force in front of us. He coined the term paradigm change. And we are indeed at the moment of a paradigm change in our systems. It has been spoken about over the last years, decades. I've been involved with this work, but I think truly for the first time, we are in a position now where paradigm change is something that we need to take seriously and think about how we can take advantage of the changes that are going on, but also to be cognizant of the nature and the scope and the scale of those changes. So the action agenda is an idea about where we are going. When we started doing this in March, and as folks on this call who were thinking about conference planning, it's very hard to do that when the puck is moving, so to speak. And as we thought about it, we didn't want to pick a point in time and say, let's go plan that then. So what we decided to do is to think more about it as an agile development process where we want to be studying where the puck is headed, where are the systems going, so that we can design, develop, create, and convene so that when we get there, we're there together. It's not a field of dreams. It's not we're going to build it and people are going to come. If we build it together, we will have knowledge, we will have experience, we'll have a learning organization that allows us to take action informed by where we are when we arrive there. And so we've formed something called the National Action Agenda, which I mentioned, and it's really a roadmap to guide the development and implementation of system level, and that's an important thought, system level cross-domain paradigm changing approaches to think about what can we do upstream, what can we do from a prevention perspective. There are certainly many, many, many things to fix, many, many things. But how can we take that energy and think about it going from an upstream and a prevention perspective so we can hopefully alleviate some of those issues? And so that's the task that we've set out for ourselves. It is big, it is ambitious, and it is significant. Our goals are to improve the health, safety, well-being, and equity by addressing some of the root causes of systematic change. Thinking about racial justice and socioeconomic disparities, especially for the most underserved, under-resourced, and at-risk populations. We want to do this by thinking about the social influences, otherwise known as social determinants, by dramatically improving responsible information sharing and interoperability across the domains. That's the place we're thinking about, is how do we change and how do we improve the information sharing that's critical at the moment in time when it's most necessary, because oftentimes we don't have that. And so what do we want to deliver as a result of this activity? We want to identify and begin delivering, implementing a few, and the critical word there is a few high value, actionable recommendations in specific locations with partners starting in 2021. So this is not a blue ribbon panel. Our recommendations are going to be implemented. There's already groups that are working with us to figure out how the recommendations actually get implemented, and so that they're implementable at the local level, at the CBO level, at the state level, and even at the federal level. And having all of those working gives us a chance of maybe doing it, of being successful. So we've set out, invited and have attracted about 100 people from across the country in all these domains. We've organized them in these social categories, these different, oftentimes thought about as social determinants or influences. And we've added a legal one as well, given the importance of civil legal in the universe, as well as some work we're doing with Pew Charitable Trust to look at the role of technology to improve civil court, both effectiveness and efficiency and access, a critical component of the work. So each of the groups is working independently to identify what matters most to them, and then we'll begin to cut across those different groups so that we have a comprehensive cross-platform, cross-determinant view. And we'll bring that together to look at those things that are relevant and resonant in each of those categories that then percolates up so that it represents the most opportune changes that we might be able to implement that could actually have a large scale change. That's a lot of words. The model that we're using, which should look very familiar to many people, is this pinwheel in many ways. And this came out of the work group. We have a group that's working on actually designing and developing a proof of concept that will actually be a roadmap, in a sense, for how do you connect these things. All of you are quite familiar of the siloization of programs, the great difficulty, if not inability, to share information across systems, the complexity of that, not only the legal complexity, but the technical complexity as well as the human complexity. And so as we started thinking about what the proof of concept would do, this vision, this model emerged. And I offer it up to you as a way to quickly convey the complexity of the kinds of problems and kinds of issues that all of you are dealing with if you're in the system of care world. And I think it in one way represents a very elegant way of looking at who we're serving in the middle and the systems of care. In fact, Steve, it looks a little like the diagram you put up there before. Mm-hmm. And so it is, I think, consistent with the approach that you guys are taking. The way we're doing our work is we're also embedding it in a scenario. And this is a use case that is actually it's fictitious, but we've created this, and this is just a visual summarization. This is the graphic illustration of a family that has a whole lot of issues, and it is a complex family involving many different physical, behavioral, legal, educational, housing, relational kinds of things. But we offered it up to our group so that we all can begin on a single point of, with a single perspective. And we can begin to look at what are the upstream issues that actually affected Sarah or Jameson or John, and how can we address those things going forward so that we can alleviate or mitigate some of those issues. And in fact, that is the purpose of the proof of concept. So I mentioned just a bit earlier that we have some implementation sites. And this is interesting to look into for those for folks who are interested in these particular models. In January, the Centers for Medicaid and Medicare Innovation actually awarded 8 grants to groups across the country. California did not apply, so you didn't get one. And they are intended to create a new payment model. Not all that much different than the accountable health communities in California, but they're attempting to connect Medicaid, behavioral health, children's services, education, housing, courts, and criminal justice. They have a 7-year runway. They're funded to do the work, and their job is to connect the dots to do that. And so what we're doing is we're helping them develop the sort of the blueprint for them to build what will inevitably be a technology solution, a legally sort of supported technology solution that enables them to connect the dots across different programs. That is an open source, open API, open standard kind of approach that we're hoping and expecting will be available broadly to any jurisdiction, and so that it's replicable. And I use the word replicable in particular because oftentimes people talk about scalability in these things. Oh, we got to make sure it scales. And while that's important for statewide systems, for these kinds of approaches that are addressing complex connections between organizations at a community level, there needs to be the ability to adapt, configure, customize. And by using the word replicability allows you to do that from a customization perspective, so it fits your particular needs. As opposed to a one-size-fits-all, the blueprint should be adaptable to the needs of your communities. As you go forward with your own system design and development, I encourage you to think about that replicability and whether or not you can add other programs, add other participants, how you connect with the state or the county or other NGOs along the way. And so there's a model here that helps us be able to say, hey, this is what we're looking at, our system of care. Here's an example of a complex child welfare case, essentially trying to keep children in their homes and not being removed from their families as a result of substance use disorder. And then actually a blueprint to help them do that. So it's all kind of wrapped up and is running parallel to the action agenda. Just the last slide here on this agenda here is a website that I think I spoke about last year for those of you who were there. It's operational now, and you'll notice on here there's a gray bar. Each of the groups actually has a subsite, a subgroup, where they're doing their work and they're posting their material. So while the whole action agenda is an entity, the community and social context group can actually do their work, post the material, ask questions, and get resources. And that allows them to stay in touch asynchronously. And it's something that we've talked about a little bit, especially for the kind of work you're doing across various counties. How do you synchronize your work? How do you know what's going on across the state within a fairly easily navigable site? And so that is beginning to work for us. We're posting notes up there. It's easy, it's open for those of you who have an interest to join it and to participate. Feel free to join it. And for those of you who are interested in learning more, there's a lot of information there. I also want to thank our sponsors who have helped us do this. As Steve and Richard know, it's a very difficult time to ask other organizations for resources and money to do these kinds of things. People are generally focused on feeding or helping people in very tangible ways. And we have been fortunate enough to find partners who recognize the need for longer term sort of strategic action efforts. And so MHSOAC, who is obviously a sponsor of your work, is also engaged with our work here. Michigan Health Information Exchange, the Robert Wood Johnson Foundation, Data Across Sectors, MITRE, FEI Systems, and Bright Hive, which is a data trust, but a very interesting way of bringing data together. And mostly I want to thank the Kresge Foundation, who has been generous in allowing us to do this work over the last couple of years. I want to mention one other thing here again, from a national perspective. We talk about the National Interoperability Collaborative, which we've been building. I spoke about it again last year, as a way to bring people together who are interested in this work from across different sectors, different programs, different domains, but don't really have a home. There hasn't been a home for disparate different domains and sectors to bring together their thinking, their ideas, and their organizations and their communities. So the NIC is really designed to be a community of networks. Each of the groups that are up here, and some of them you may be familiar with, are in many ways doing similar to what we're doing and to what you're doing, in fact, looking at system level change in very significant ways. And so we've been engaged with them and are engaged with them and hoping that our work will combine and synergize with them so that the efforts that are going on are connected at a national level and at a regional and at a state level. So we're not just all spinning our efforts in vain or in solo. And so there's some momentum, and I'm here to share that there is some momentum around really building these kind of, many of them are philanthropic efforts or association level efforts. And so that's good news. That's really good news that there's a growing trend to bring together communities and networks. And we hope that you'll join it as well. let me pause for a moment here. We're going to move into some sort of fundamental concepts on interoperability, but just pause to see if people have questions. Or Steve or Richard, do you have any comments you want to make before we jump into the next section here?
I don't see, Daniel, any questions at this point in chat, but just really appreciative of the complexity of this conversation and the imperative. If we're going to do integrated care, we got to figure out what the common language is to share information. So love the energy for it.
Thank you. Yeah.
To build on that, I really like how you differentiated between the technical issues, the legal issues, and the human issues, because people often get stuck in one or the other and never think of the others. And so we can make movement in one while we're still learning how to work out some of the others. So I'm glad you're going to be able to bring some examples going forward, not today, but certainly in the resources that we share later. And clearly, I think there are a number of counties in California that have moved pretty far in all three of those areas. There aren't many that have moved across all three, but there's ones that have done made some real progress in each of those areas. So this is exciting. Bodes really well for the immediate future.
Yeah, thank you. Despite the ominous clouds all around us.
Yes, true.
There are a few silver linings. Just to that point alone, the work we're starting up with Pew Charitable Trust, they're very involved with courts and improving courts, particularly civil courts. And one of the things that has evolved from that work is I guess the silver lining of sorts. The courts obviously were not able to function very effectively, and many of them have moved to virtual formats. And what they're hearing and what we're beginning to hear is that actually that engagement across the screen in many instances is not a great thing for many people. From a court perspective, they're actually finding it to be actually really positive in many ways. There is a reduction in stigma. There's a reduction in fear, a reduction in going to the courthouse if you actually are worried about citizenship status. And having a personal relationship or a less formal, more personal relationship with judges is finding a lot of compliance and some interesting things that are popping up out of that are probably showing up in other places as well. Obviously a lot of downsides, but there are some things that are actually effective and really positive report. So let me jump into this again. There's not this is not going to be an exhaustive presentation on interoperability. So for those of you who've had a long day already, I'll assure you that we're going to get to the point here. First of all, I want to just very briefly define interoperability. And Steve, to your point just a moment ago, oftentimes and historically, interoperability has been really a technical solution or a technical concept, right? And people who are not on the technical side, I'm not a technical person, although I've learned a lot, all of a sudden just recede from the conversation. Not part of it. I don't get it. I don't get the bits and bytes. Tell me, tell me what I need to know. Over the years, that terminology has changed. And so I think while it certainly still has a very technical connotation, the way we're using it, the way I'm using it, and the way I think many, many people are now using it is beyond the technical engineering sense, so that it offers a broader context, including social, legal, political, organizational, other factors that impact performance. And so when you hear the word, because it's become only the last 3 or 4 years, it's become part of our lexicon. And language is important. The other definition, which you may probably are already intimately familiar with, is this idea of upstream, which in my mind is just a euphemism for prevention or early detection. But it's kind of got a new way of defining those activities as opposed to midstream and downstream. Important to differentiate those activities, but also something that is and has been historically woefully underfunded and paid attention to, which is unfortunate, but the reality. We're hoping to try to change that a bit. So very briefly, I think that from an interoperability perspective, sometimes the pictures are worth 1,000 words. And I apologize if I think I might have shared this last year. For those of people who are new to interoperability or want to try to explain it to their boss or to their spouse or to their friend or something like that, these three slides are really important. So you've got a family, you've got mom, you've got her daughter and her daughter's baby. And each of these people are involved in some way with different systems. Again, it's a variation on the picture we showed and on the system of care. And that mom is involved with healthcare, the baby is involved with child protective services, early education, you know, all of these different things. Each of them are receiving a bunch of different services. You look at this and you say, wow, this is just one small family, and the complexity of the service coordination, no less the, you know, sort of the actual delivery and receipt of effective services is horrendously complicated. And that what we're trying to do is to figure out a way through person-centered or holistic care or whole person care to say, let's be able to bring that information together. So at least we have, in an ethical, responsible, moral way, the information that's necessary to support, hopefully intervene in a positive way early. And that's where interoperability comes to play. Interoperability is really the ability to not only technically do that, legally do that, but also get systems to play together in the sandbox, as it were. Okay, so a couple of language things and different definitional things that I think are really important. When we think of the kind of change that interoperability requires or system of care requires, it does cut across many silos. It cuts across many levels. It cuts across sectors, public, private, nonprofit. It cuts across hierarchies, and it cuts across functional responsibilities. It's basically it's a rubric cube. If you technically think of the different pieces that are moving, there's a lot of moving pieces. And so consequently, there is a horrendous amount of misinformation and miscommunication that happens. We know how hard it is to communicate on simple things. On these complex things, it becomes even more difficult. What we're offering here is a simple sort of theory of change model. Again, this may not be totally novel for people who've been in the system of care world before, but for the folks we've worked with, it helps to differentiate. If you think about the pillars, are we talking about a policy conversation? Is this conversation about policy, legislation, regulation, statutes? Are we talking about a structural question? Are we talking about the bits and bytes? Are we talking about buildings, co-locating? Are we talking about workforce? Are we thinking about those kinds of things? Or are we talking about practice? How does the work actually get implemented? Who's doing it? Who's got the oversight? What's the governance for that? And oftentimes we can have a conversation and you're talking from a policy perspective and I'm talking from a practice perspective. The potential for lack of communication or miscommunication is extraordinary. So even simply clarifying what the basis of the conversation is going into it is we're talking about policy here, right? We're not talking about the implementation that will follow, as opposed to talking about the structural components and saying, we need to change policy. Well, that's okay, but we're not talking about that. We're talking about the structural components. Two other parts of this to think about. One is how innovative are we trying to be, and how rigid are we on trying to define the outcomes? The more defined we are on outcome measures, metrics, the less opportunities there are for innovation, I would say. That equation needs to be thought about. Do we know that we want to get a 6.2% increase over the next 12 months for the $2 million investment? Well, you better be very focused on the outcomes. Innovation does not necessarily provide a clear path to results. That's a decision point you need to make. And then, of course, the other 2 points of how quickly you're going to make those changes. Is it an incremental change? Is it evolutionary? Are we going to evolve this, iterate over time? Or is it revolutionary? We got to do this tomorrow. We got to change our courts from people filing in the front door, going through the metal detectors, to doing it over the web. That's a revolutionary change that actually involved quite a bit of innovation to make that happen. That affects a lot of different things. So just at a high level, this simple model can help just eliminate some of the communication barriers going forward. and I offer that up. I am missing some slides here. I apologize. Okay, I'm gonna come back to those 2 slides there. I just not to make it a mystery here. I don't know, these are out of order for some reason. These are some resources that I'm going to come back to at the end here, just so if you were wondering what they were around interoperability, and I'll come back to them and talk about them for folks who want to dive more deeply into it. And here's some examples of some of the jurisdictions that are sort of best practices, so to speak, out there in the world. What I'd like to talk about next is our new training program. It's a way to take these concepts that I've just been talking about and put them into a training curriculum, an educational curriculum, because this stuff is really complicated. I mean, it is as I said, it's a 3-dimensional rubric cube. And as a result of that, it can be incredibly difficult to come at this without a structured approach. And over the years, as we've worked with different organizations, jurisdictions who are interested in interoperability, including California and many counties in California and elsewhere, what we've seen over the years is people generally start with a blank page. All right, we want to do this system of care work. We want to do this whole person care. Let's figure out a process to do it. And then let's figure out how we're going to get people on the same page to understand all the moving parts. And so what became clear, and what part of our work with the Kresge Foundation was to try to document this and to put it into actually a training program. How do you teach system thinking? We're talking about systems of care. When have you sat in on a systems thinking class? It's a very different way of thinking about problems. And I'll show you a few things here that I think just from a simple perspective can help really put this into a dimension. In fact, I don't believe she's on the call here, but Carrie Miller, who is in Los Angeles County, years ago attended one of our events, and one of the people I learned this work from at Johns Hopkins at the Applied Physics Lab gave a very long, detailed systems engineering symposium. And that main concept of systems engineering was something Carrie took back to Los Angeles and started to rethink about how to even envision the complexity of all the different programs, as opposed to thinking about integrating them all into one giant new data warehouse or something like that. The idea of being able to think about it from a system of systems perspective, and I'll share that with you in just a minute. So the implications are right at home in your backyard there. ITCC also provides the common vocabulary, a little bit of which I've shared with you already. It's a set of knowledge and skills and tools and competencies needed to build and sustain interoperability efforts. It's the language. You don't need to start from defining the language and the tools and the models. We spent a lot of time doing that. They're available to you. And they're designed to help people and organizations implement and sustain responsible information sharing, especially around value-based care and person-centered care. So it's designed specifically for that. We're also designing it somewhat by chance, but fortunately on kind of an agile basis. So we're creating modules. We're actually in the middle now of creating our next modules, which is around privacy and confidentiality. So how do you teach that, right? And there's a series of modules that we'll be rolling out. The fundamental concepts in ITCC are these 3 as a baseline. The module itself is the core course. I'll show you just a few pieces of that, but just to give you a feeling for it. Because what I mainly want to convey is the fact that this is actually teachable and learnable. Staff, managers, supervisors can actually learn this kind of knowledge, this kind of vocabulary, this kind of language, and accelerate the work you're doing, because now you've got common concepts and models, as opposed to figuring them out, they're applicable. So first of all, social determinants. That's probably not new to anybody on this call at all. Social influences, social, whatever you might want to call them. But it's a recap of that, and it's a recap of making sure everybody we're talking with really understands that there are many different factors that go into health and well-being. The middle pillar, called 6 primary domains. this is what a piece of work that we've done now, what we've been really focused on for several years under the NIC, which is to say, yeah, we work in human services. We work in, and human services has got all these different programs, social program, child welfare program, all these different food, nutrition programs. But guess what? There are many other domains out there. There's public safety, there's public health, there's healthcare, there's education, there's emergency medical. Each of those domains is its own universe. They're all looking at internally saying, we got to get better at public health. We got to get better at delivering healthcare services. Now that social determinants has finally become a commonly understood and believed concept, how we blend those domains, right? Very consciously thinking, boy, if we're going to make a change, if we're going to change a system, or we're going to change a law, or we're going to change a practice, guess what? In a hurricane, in a fire, in a natural disaster, all of those 6 domains are called upon, right? Sometimes 4 or 5 or 6 or 3 of them are called upon. The interoperability is not only within one of those domains, but it is across those domains. So what we do a little bit here, and we wrote a pretty extensive paper for HIMSS, which is one of the partners you might have seen. HIMSS is the largest worldwide health IT association. Their conferences attract over 50,000 people. So their interest in, again, another bit of good news is HIMSS, which is all about health IT, which supports a $4 trillion budget, is now interested in social determinants. So how do we take our thinking and spread it across, or at least make these other domains aware of what human services is trying to accomplish? Because we need to exchange data with whether or not it's the ambulance, or whether or not it's the EMS provider, or the cops, or public health workers. That vocabulary is not something we're comfortable with. We don't understand it. We don't understand, even if we had the data, we might not even understand what it means. They use different terms. You know, is it a person? Is it a client? Is it a perp? Is it whatever it is, there are a lot of challenges in that. So even creating that awareness that our universe is big enough is a much larger universe. And then the last concept of systems engineering is what I referred to just previously. This is probably the most important concept. You don't need to be an engineer. You don't need to become an engineer. It's actually a very simple concept, obviously very complicated to implement. When Charles Picard, who was at the Applied Physics Lab, was working with us when we were working at the Administration for Children and Families, and they actually are the rocket scientists, I like to say. People always say, well, we're not. They literally are. You go into their building and they've got the rocket science stuff all over the place. The way he described this and the way he saw the application to the work that we were trying to do is that if you think about Army, Navy, and Air Force, each of them are a system. And those systems are designed and purpose-built to do what they're doing on the land, on the sea, on the water. And yet they need to coordinate very, very closely for all the reasons you can imagine. They did not build an Uber system, right? There is no integrated platform where all those guys work together. They each maintain their own systems, sort of honed to their specifications, but they've created a system of systems, which means sitting on top of those individual systems. You think of it as pie tins. There's another system that aggregates the relevant and information in a timely basis. That's just what's needed. I need to know X and Y from Air Force. I need to know A, B, and C from Navy. We put that information together for either delivering troops or whatever else might happen. In much the same way, I think our HHS world is designed that way. And that idea of system of systems is saying all these different systems are out there. Trying to coordinate and integrate them all is an impossible task, incredibly expensive, will never get done effectively. But if we think about optimizing our systems and then think about how do we draw information from each of those systems, that becomes doable. Because we're not trying to ask each system to change its way of doing business. We're just asking for an API, the ability for that system to say, here's the information I've got, here's how you can read it, take it what you need if you've got the right credentials to do that. And so at an agency level, where you're coordinating, maybe 6 different programs or whatever, or at a county level where you're coordinating multiple programs, or at a state level, the same kind of concept plays out. I invite you to actually, on our YouTube channel, you can actually take in, if you go to the Stewards of Change Institute YouTube channel, you can actually take in that whole engineering lecture, which is fascinating if you like that kind of thing. And we distill that in the program, in the training program. So the other part of the program, there's a couple more slides, and we're getting close to the end here, is this idea of human-centered design. We use a lot of graphics, partially because a lot of the world sees in pictures. They think in pictures. And oftentimes all we do is give them words in lots of documentation. So we've developed and designed, and many of you may have seen some of the work we've done around this. This is work we did for the state of Connecticut, the Department of Social Services. They're building a unified department to look at trying to serve people more effectively, kind of a system of care. And so we created the Benson family so that everybody in the organization, whether or not you're a frontline worker, supervisor, manager, could actually see and understand who we're serving, how we're being served, and my role as a contributor to that. I might not be a direct service provider. I might be doing finance. I might be doing technology. I might be doing X, Y, or Z. If the organization brings me into that conversation, I see the benefits of I see the impact of my efforts. I become connected to it. I see where my effort goes. This is just an example of looking at the family, creating a story around the family, and trying to understand, what do they need? What are the systems we have provide for our ability to understand it? And what's the gap in between those things? That's a rich conversation that yields lots of insight about the stuff we don't ever collect. We don't collect a lot of the stuff that's really relevant to people in these systems. So we do a lot of that sort of visualization work, and that is complemented in many ways by this model of our interoperability model here. Very briefly, this is a way to think about all of the different drivers that an organization needs to pay attention to. We don't have time to go into them, but these are the core levers of management: knowing about leadership, silos, privacy, public will, et cetera, et cetera. So we've done a deep dive into this work. There's a rubric for each of these. We've created a whole series of evaluations that allow organizations to actually do their own assessment of how to understand what and how they're doing it. That assessment sort of shows up on a matrix like this. So how important is information technology? Well, gosh, it's really critically important. How good are we at it? Well, we're not very good at it. That puts you down in this quadrant. You begin to see a picture of your strengths and development needs. And everybody in the organization can go through a pretty rigorous or a qualitative process to understand the capabilities, the needs, where you're going to invest your limited resources based on an assessment of where our needs are and our assessments are. And so that's another piece. All of these things are part of the training program, and that goes into that. 5 agencies in California have already piloted it just fairly recently. And we are excited to talk with others who want to do it. So there we are. Let me just go quickly up to those 2 other slides just to let you know what's here, and then we can open it to questions. If folks are interested in the technical aspects, the Office of National Coordinator, Accelerator programs, under this administration has continued to really drive a very significant positive direction on connecting systems, mostly in the healthcare space, but they're attentive to social factors as well. There's a program called Integrated Care for Kids, which I encourage you to take a look at. The Administration for Children and Families is now just got a new lead for their interoperability efforts, so we should be seeing more at the federal level around interoperability, which had gotten started and then stopped. One of the things we did was we did some work in California developing the interoperability and strategic plan, which is available, which outlined a lot of these pieces. And then there's a lot of work by foundations up here that I mentioned earlier that have very robust kinds of information that you may or may not be available to you. I offer you these as places to go look for places that are doing a good job trying to move this up the mountain here. So that's, I think, my prepared remarks for today, if I'm not mistaken. Yep, and so there we go. Back to you, Steve and Richard.
Well, thanks. You certainly highlighted both the legal, the human, and the technical aspects of this. So thank you, Daniel. And I just want to make sure everybody understands that the webinar will be posted tomorrow on the website, so you can download this. I know I'm going to have to watch it at least once more. And I'm a New Yorker, so I can keep pace with his speed of speech, and I'm going to need it once more. But also, more importantly, I think the resources that are available are just rich. So Daniel, thank you so much. I think you've given us a base by which we can all leap forward, knowing that we're not sort of just trying to recreate the wheel or spinning our wheels. So thank you very much for that. Richard, your thoughts?
Daniel, I'm wondering, I loved your last slide and the linkages to some of the local systems. Given that we've got a couple minutes, and if it's possible, it may not be, but if it's possible, could you elaborate on maybe one of those, and like what are the local successes that one of those implementation efforts are having?
Sure, let me just pull up that list here for a second.
Past it, there you go.
Yeah.
Well, I think being in California, I think you probably, let me ask you a question. I don't know how familiar you are with the work that's going on in San Diego. They've been doing this work for a while now. Although I'm sometimes surprised at, given how big California is and how,
This should be fun.
Looking for the right word here. I don't know if anyone from San Diego is on the call here or not, but they've been at it for a while, which is the hallmark of virtually everybody else on here. This is the long march. So you know, they've invested heavily. They've thought a lot about many of the kinds of concepts I've presented here today. They've pursued it aggressively. Have tried, failed, and then come back again, and are really pushing hard on the community information exchange, which is something that has been picked up now by a lot of different organizations across the country, that allowing people to not only connect the county-based information and the open data kinds of stuff and the 211 stuff, so it's all kind of integrated together, which makes it very, 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 very useful.
Yeah, and Daniel, just to build on that, the 211 CIE just had a summit, a national summit, and so if people are interested, there's an incredible amount of resources and information from all of the webinars and presentations that were all done virtually, so all of them are available. And they're actually now moving forward in how do you integrate information from agencies that are referring clients, as well as organizations that are receiving them, and how do you continue to have dialogue across that rather than just passing them off and forgetting about them. So there's some interesting, I think they're up to over 400,000 shared lives. That's how they describe it.
Yeah. You know, see, I just point out one other thing. Chapter 55 in Massachusetts, for those organizations that are still addressing opioids or the resurgence of it or the continuation of it, they have been able to share data in a very, very robust way. I don't think they presented it at an event we held a couple of years ago, and I was super impressed with the governance that they were able to drive across the state, all the state agencies, a lot of the local agencies, to really bring together a comprehensive picture so that they could actually deliver kind of coordinated care around opioids and meth in a way that was really unparalleled at that point in time. I know there's a lot of work going on elsewhere. So
thank you for that.
Yeah, I would even add something about Allegheny County, which is a county pretty comparable to many of those in California in terms of diversity of people served and the needs. And they've been, as you said, Daniel, been at it a long time. They've even been moving forward in terms of predictive analytics to try and think about how do we get upstream knowing the conditions that we know and trying to make offers of engagements before it hits a crisis. So there's a lot of interesting stuff going on.
Yeah, I would just add that Allegheny has been a longtime SAMHSA grantee for their children's system of care. And so if you're on the call today listening and you want to see maybe where this interoperability conversation impacts really close to your system of care work as you're thinking about 23 in California, Allegheny might be a good place to kind of dive deep. Well
said. All right, so folks, questions? We don't see any, or I don't see any. Do you see any, Richard?
Nothing yet.
Do you think that means that we've filled their cup and they have nothing left to share or ask?
Well, as usual, Daniel's threaded the needle here and gotten a tremendous amount of information to our group today. So yeah. Let's give folks maybe another minute or two to ponder on what's emerging.
Yeah. And so, and again, just to reiterate, all of this material from the webinar and Daniel's resources will be available tomorrow on the website where you registered for the webinar, as well as all of the resources that are listed at the end of this document. And I would remind you, if you were at Breaking Barriers last year, that the toolkit has 4 elements, shared governance and leadership, shared resources and finances, shared data and outcomes, and shared community. And going forward, that's how we've organized this year's Breaking Barriers Symposium. Obviously, we couldn't meet 2 days in person, so we created 4 half days of virtually so that we could address in a deeper way each of those 4 pillars. And the first one is October 29th, and then the next 3 consecutive Thursdays in Thanksgiving in November, and then we can all be thankful. But please look at those and register. And this week, I'm told that there's a 15% register early reduction. So this might be your week to do so.
Well, thank you for the opportunity to share again this year with you. And I think my contact information is up there as well. So if you can't find me through Steve or Richard, feel free to explore the resources. There's lots of material up there for folks who want to dive into this stuff. And come join get the hub and join the hub, and you'll get the mailings directly about the stuff we're doing there as well. So
you get lots of them, by the way, folks, just so you're aware.
We've cooled off a little bit lately.
Good stuff. I manage. I want to look through it, and because it's worthwhile. So thanks very much, Daniel. As always, thanks, Richard and Jamie. Sight unseen, as always, you hold us all together. So thanks much to you as well, Jamie. Yay.
Thanks, guys.
Thanks, guys.
Thanks all.
Be well, stay safe, and hope to see you in Breaking Barriers Symposium, October 29.